Mark Wagner here. As you can see to my left, I've got a co-host here today, Mr. James Neuber, and we have somebody that will be joining online. But very first and foremost, I have to mention some of these things because that's how I pay for the electrical and all that kind of good stuff. So first and foremost, if your practice is not listed on dentistondemand.com, go and check it out. Simply dentistondemand.com. Click on doctor. We have several different packages varying from $50 a month to $2,000 a month. Just a great add-on to the amazing strategy that you are already hopefully doing in your practice. The second is Smile Sonica. Smile Sonica is a great Canadian company based in Edmonton. They have an orthodontic device called the Avo System. What is the Avo System? It biostimulates osteoclasts and osteoblasts, and it helps teeth move. I'll leave it at that. It's smilesonica.com. That's it. There, you gotta tick off the boxes in these things. And there we go. We'll just bring him on. Dr. Bradley Bishop, the Legato Centre. So I put Legato Dental. You're doing some brand changes. How's practice life today?
Good. Yeah, we're having fun. Making people smile. So
if you're not having fun, what the heck are you doing? And Jay, how's the laboratory today? Anything interesting going on?
Wow. To ask me a marketing question in Ocean, I might chew up the whole 45 minutes that we have allotted for today.
You're not going to chew anything up with that jacket you're wearing there. Let's just bring it out here. So you guys are collaborating on an amazing Smile course coming up. We just want to dive into that conversation.
And a hybrid course.
Yes. So one of the things that in this conversation, and I will butcher anything clinical. So I have two very well versed folks in online today with me to discuss. Starting off, Brad, as your specialty, what kind of issues are you fixing? Like you must see a lot of crazy things in your front being referred to you. Like, what are some of these sort of the commonalities that you see? Maybe even get into some like really complicated and difficult cases that do you find yourself as a problem solver more than anything with your specialty?
My practice is built on other people's failures.
So what have you seen on that front? Like is there any sort of noteworthy things that come to mind?
I think the biggest, I think the underlying challenge that I see is a lack of foresight in planning. I feel quite fortunate that my practice is built on managing failures, because when I'm treatment planning cases, I am asking myself the entire way, how is this going to fail? And how can I manage that? How can I mitigate the potential for that failure? And, it comes down to simply planning appropriate number of implants to support a case, managing occlusion, managing and properly evaluating smiles, lip animation. There's a host of different questions, but it really comes down to planning and vision.
So, Brad, are you looking at it as, say, compromised cases that show up? Is it most of the time function, or maybe the cosmetic vision hasn't been hit, or combination of both?
I would say it's a combination of both. I mean, I do see, I have a lot of patients who are referred because they've been dissatisfied with the aesthetic outcome, or there's been functional failure. They present to a different dentist, and that dentist doesn't really want to get involved, so they refer to me to dissect the case and understand the patient, understand what they're looking for, and then deliver a solution that meets their needs and desires.
So it almost sounds like an irony here, Brad, that you're usually mopping up messes, whereas, and here you've invested all this time to prepare a Smile Mastery course. We're almost equipping doctors to do it right the first time, and those patients not even showing up in your practice. It's kind of a reverse, a reverse system. It doesn't sound like the best marketing thing for you.
So let's dive into that. So where does that start? Like you mentioned, having the foresight, the planning, the insight. And now is that sort of, is that what you're mopping up, is just the lack of the planning aspects? And also we should dive into, who's a good fit? What folks are you seeing coming through the door, and when are you doing sort of that smile case, and who's a good candidate for that?
That was a lot of question.
Yeah, unpack that. Good luck. Good luck, Brad. Back to you, Brad.
Yeah. So, let's see. Where do I start with that?
Where do they need to line up to be successful? Just to start, where do their minds have to be to start?
Where does a doctor's mind have to be to start?
That's right. Where is it a confidence thing? Where does it begin?
Well, we've all been on the journey, right? Even a guy like me who's been doing this for this will be the 20th year since I graduated from dental school, and I've been practicing as a prosthodontist in this community for 17 years. So, everything that I say has a great element of my own failures and experiences, but I think the first step really comes to truly understanding what the patient is looking for. And one challenge, I think the starting challenge that I see is that a doctor's trying to fit a patient into their patient plan, rather than truly seeking to understand what drives that patient, what are they looking for, and delivering solutions for that.
And how hard is that to match, that conversation with the patient? If we speak in terms of a veneer case, what if they're not periodontally? What if they're not even a good candidate? Their oral hygiene's terrible. Where does that sort of that match meet? The patient dream versus the actual clinical formula.
I think the biggest barrier that people have is time, and that's I feel quite privileged in that way that my practice is structured around dealing with bigger cases, and so time is structured in my day to sit and listen. And when you're bouncing from the screaming kid in room 5 and room 2, the 2 hygiene checks in room 3 and 4, when do you have time to sit and actually listen to a patient say, this is what bothers me about my teeth? And so I think that's the biggest barrier, is just setting aside appropriate time. Right. And when you have that appropriate time, we're talking about aesthetics here, but handing a patient a mirror and asking them to point and describe exactly what they don't like. Is it color? Is it shape? Is it display? Is it, what is the concern? And so I think that's the biggest challenge, is just really understanding what the patient is looking for. Because I think once that's clear, matching a plan to that is pretty simple.
Yeah. Oh. How often do you see somebody that's been to somebody else, maybe a GP, maybe whoever, that the patient didn't get what they thought they were going to get too, because that conversation didn't happen?
So again, my practice is a landing zone for cases like that, but I mean, I see that quite often.
Yeah.
I can't necessarily say that that's the norm, but it is common in my practice. So
Yeah.
the other piece, the listening piece is then properly collecting diagnostic records and walking patients through what's actually going on in their mouth, which expands the scope of what they want.
Mm-hmm.
When they understand what's happening in their mouth, they see photographs and they see models, and then they see what the possibilities are. All of a sudden, many patients will go from, oh, I thought this is what I wanted, but I actually want more.
Yeah.
Because now I understand what the problems are, and I understand what I'm leaving on the table with my little desire.
Brad, when do you bring the laboratory into the conversation? When's that appropriate time?
James, how long have you been working together, James? 15 years?
Ever since you moved to Kelowna.
Yeah, 17 years.
Yeah.
We got started together pretty early on.
Yeah.
And so, with a specific case, the lab is involved very early in understanding what's possible. We've been working together so much that I think we understand what each other are capable of. And so perhaps less of that conversation happens nowadays at that initial consultation.
Right.
Because we've already done so many cases. But when you're doing that initial workup and exploring with your diagnostic records what's possible for that patient, getting the lab involved and saying, hey, this is what I'm thinking of doing. Can we do this? Can you do this?
Right.
It's really key before you present to the patient a solution that the lab is like, I can't do that.
Yeah.
Or that's going to be a problem for the following reasons, which is one of the reasons I love working with James and his team at Ocean, is that they're very tactful and respectful about identifying things that we oversee as clinicians sometimes.
You always need another set of eyes.
Mm-hmm.
I mean, you guys, like when you guys are in the mouth with the blood, sweat, and the tissue flapping around, and when all these factors that we're not subjected to, a second set of eyes is very, very helpful for comprehensive care.
And I think too, like just to add to that, James, is like the relationship that somebody in clinic would develop with the laboratory
And
too.
the trust.
The trust, obviously, you said it, Brad, like, you know what they can and can't do. You know sort of what they're looking for in terms of records, which is another huge part of it too. It's all about patient outcomes, right?
I have to go back and address what Brad was talking about, finding out where the patient's at the beginning of this journey. And after hundreds and hundreds of smile consults, I pretty much love it when a patient shows up, and I already in my head, I know it's going to be a 30 to 60 minute consult, because the very first question that I ask a patient is, can you tell me about your journey in dentistry that's led you to this decision to invest in some new smile work of whatever is on hand? And then I just sit back and listen, because they digest and expose to me. First, they're always going to share the negative experiences in the past. So I always know, and the clinician then will know, what are the landmines that we have to be aware of moving forward. And then I have to extract the vision in their head. And usually, they'll tell me, well, I don't want turkey teeth. I don't want this. I want it to look bright and natural and all these other things. But there's two things we try to nail down. What is the shape, and what is the shade, the brightness level that you want your new teeth? And with that, we have all sorts of tools to find out what the vision is. And then we talk with the clinician, how do we reverse engineer this, that's what I have found has been so proactive on working with any clinician on, designing a smile. Because there's one thing that I've noticed on my end of the lab end, Brad, when I talk and interview patients, and a lot of the interviews sometimes they turn into counseling appointments because they share lots of negative experiences in the past. But one thing I've noticed for sure is that one of the number one reasons people want to invest in a new smile, whether they need to open the vertical or not, is they want to invest in their self-esteem.
Mm-hmm.
And so when we know that as a profession moving forward in any smile work, we get caught up in the tooth, the gums, the bite. But you know what? One thing I learned from Patch Adams, one of my favorite movies of all time, is, and he said it best, when you treat a disease, you win some, you lose some, but when you treat the person, you always win. And so that's always been my approach when we start planning a case out. I want to know about the person a lot of times. And then if we can improve function, all these other things that we talk about in dentistry, man, you're treating more than the teeth. You're treating the person, and that's the X factor between these treatment plans.
Yep.
That's the X factor that separates one from the most.
And what is really cool is that's why dentistry will always be a people business. Like I just did I had just had a conversation with my last guest just about that. Like it's all about, if your mind floats towards the production side and you're too busy looking at numbers to think, that's it. Like if you're having these conversations and like how much, like Brad, I'm looking at this stuff from the outside. How cool is it when you get a patient through and, they've gone through a portion of their life with, self-conscious with their smile and like seeing them after the fact, like when like that first, the first time that they see themselves in a mirror, that must be like some of the most beautiful moments that like any human can experience. Like the smile is one of my favorite pictures that floats around the internet all the time is you have this guy smiling and he's got his family around and he's missing a tooth, right? Right. And he said like one of his centrals are gone, but then at the bottom caption it says, "Did you also notice that he's missing an eyebrow?" And like they'll have like one eyebrow shaved off. Like this work is awesome. Like
You should test that on a podcast one day.
Yeah.
Black out a tooth and shave an eyebrow.
Just like the that video that like every motivational speaker's like with the guys playing
the balls,
passing the balls back and forth, and then there's like a bear that walks through.
Gorilla.
How many people saw the gorilla?
Yeah.
Anyways, off on a tangent. So, that initial conversation seems to be the equation of it all, isn't it? Because that's what you want to deliver on, and that's what you're building around. What if that equation doesn't work out? Like, how does you take that equation and then hopefully give them close to, like, percentage-wise, how close do you get with their wants and needs? Or is that something you're having a conversation with, during the initial stages is, guiding them to a mutual decision on those things clinically? Like, sorry, I can't give you, you've done some like fangs at some point. Like,
I think what Mark's asking is, how do you separate from the reality of what you can deliver from the fantasy people expect?
But I mean, the reality is that most people don't know what they want.
Sure.
Good point. Yeah,
it is.
So when they know what they don't want, but they don't actually know what they want.
Correct.
And for us as dentists, we understand what a normal, healthy human dentition looks like and functions like. They do not know what that is, but we do. And so using some very simple principles like managing the midline,
Yeah.
managing incisal edge position, managing incisal edge shape, managing vertical dimension. Pretty much if you nail those 4 down, you've got a happy customer.
Yeah.
And as soon as you get them into a prototype restoration, a set of temporaries, I like to think of them as prototypes. I tell my patients they're prototypes. If you don't like them, all I need to know is that you don't like them. I don't care.
Yeah.
If you like them, all I need to know is you like them. It
Yeah.
doesn't matter. Because if you don't like them, I know you don't like them and we can change them. And I know if you like them, James can copy them.
Yeah.
Yeah.
So,
And that's why we created on our website the My Smile selections.
yeah.
Because like you say, Brad, they come in and I says, okay, there's 2 things we want to achieve. And now the patient's thinking, okay, what are the 2? I said, one is shape and one is shade, brightness level. How bright do you want them? It's like the dimmer switch in your living room. So we have what we call the My Smile selections, and it's just something to shortlist a vision where do you want them straight, curvy, round? Just give me an idea, like something of a ballpark, and there it is. So there's an aggressive, and if you hit the arrow mark, and I just tell patients, do you have an idea of what you just find is appealing? This is not like a contractual commitment, but we need something to reverse engineer from. And one of the things we also do with this tool is we're doing now realistic AI photo simulations of taking a My Smile design and actually realistically putting it in
Nice.
to a patient's face just off of a selfie, and just to see right out of the gate if this is something you want to explore. And that's actually a free service that we offer at the lab now. I don't even know if we told you about that yet, Brad, but somebody can basically on the spot on maybe a hygiene appointment or a consult send us a photo. And within 10 minutes, we could get it back to them to say, is this something you'd like us to maybe discuss a treatment plan about? It's not totally no commitment. But unlike other AI smile designs, we've actually got technician, what do you call it, algorithm, for what's possibly doable with their existing dentition. So it's just something to flag where the patient's interest is. But it all begins with the vision. We got to nail that down, and then we reverse engineer from there.
How difficult is it to sort of, because everything's so subtle, when you're looking at all those, the incisal edges, and how, if only if you're, they have a hard time making a decision. If you're giving them more choices, does it then make it more difficult? How does that how do you wrap up that initial consult to, okay, we're both on board with this this game plan?
I mean, the My Smile tool is very useful because a patient can just scan through them, and they'll usually narrow it down to 1 or 2.
Yeah.
Yeah.
If not 1, and I often, if they're waffling between one design or another, I will steer them to the design that will give me more material to work with.
Right.
Subtractively. Because I
Subtractively.
can easily subtract. And really, I mean, with some flowable, and I can add as well, but it's just easier to subtract. So I'll steer them that direction. And I mean, like I said, 90% of the time, if you get the shape close, it's such a vast improvement from where they were. They love it.
And the central length, that initial central length and the incisal edge outline, that's 90% of capturing the vision that they see in their head. And that's the toughest thing to find.
Do you encourage them to bring like pictures of celebrities? I don't know. Is that like, do you?
Sometimes. I like it when they bring it just so that it gives them a voice.
Yeah.
Whether it's hogwash or not is a different reality.
Yeah.
A lot of people do have images that they like, and it is really helpful for them to bring them, and it's helpful to discuss them. Like, what do you like about it?
Right.
Because, is it Is it the fact that the laterals are like a millimeter shorter than the centrals?
Mm-hmm.
Is it the fact? Is it the shape of the incisal edge? Is it and you can kind of parse out basically like the My Smile tool, but they've brought their own My Smile tool
Mm-hmm.
of teeth that they like, and it
Julia
is really
Roberts, right? You know,
Oh, I've had that one.
Just make me Julia Roberts.
I know it's the when you
Then
get
you gotta make the mouth bigger, right?
the
That's
lady
it.
that comes in where her smile zone goes to the first buys, but she wants a smile like Julia where it goes back to the 9s and the 10s, you know.
Yeah.
Well, we need to X-Acto blade your cheeks back.
That's what I was just saying. Like
4 centimeters.
full full Joker.
Yeah,
You know?
the Joker.
The
smile,
Joker
yeah.
smile. That's on the list. It's number 4. So after this discussion has happened, you've captured all of this information about what the patient wants, with some of your clinical information as well. Where does it go from there? Obviously function is a big deal. Having a conversation about vertical dimension and jaw joint and all that great stuff, I know is part of that.
Pre-screening them.
But how then are you going to plan this case to it's a successful outcome? Take that one and chew it up.
So I mean, essentially, in discussing things with the patient, I've come up with a vision of my head of what's going to meet their expectations
And longevity.
Right.
and longevity. Yeah, they don't think about that, but I do.
Of course.
And,
I hope so. I certainly hope so.
But Brad, it's interesting you say that. You do. But what we see on the lab end of things is a lot of offices don't think longevity. And when a bite is too overclosed for whatever materials or function, a lot of times, a lot of clinicians aren't seeing the effect of jaw joint position, airway, overclosed bites, malfunction, all these functional things that literally can destroy dentistry in a very short order. That's one of the reasons why we wanted to see or ask you at the beginning of the pod of, what's the gnarly conditions and the whys of why these patients show up at you? Is it functional or just cosmetics or tissue blown up, because of fit and bonding protocol, or, these are all the things that cause these cases to go sideways that take us away from longevity, right?
Yeah.
So what would you think, or actually how do you pre-screen a patient function-wise as far as, do we open the vertical or not? Because that's not on a lot of clinicians' radar. When do we open vertical or not?
That's a great question. The general answer that we are taught in dental school is that you do not change vertical dimension. And
why?
Even because it's scary.
Yeah, fair.
So the reality is, we're trained that changing vertical dimension exposes us to risk in terms of joint pathology, myofascial pain, etc. On the flip, unfortunately, we're not also told that by not considering vertical dimension, we're exposing ourselves to problems like myofascial pain, occlusal dysfunction, TMJ dysfunction. And so vertical dimension, at least when I went to dental school, which, it's 20 years ago now, vertical dimension was something that was just, we're told that I basically left dental school thinking it's dangerous.
Okay.
At this
And you have to
point,
be an alien to attempt to open it?
Yeah. So that's the way I would train. Having changed vertical on, I don't know how many cases now, hundreds, if
I would say hundreds, yeah.
And at the very least hundreds. I think it's a very overlooked opportunity for so many people. And there's very safe ways of approaching it. We'll discuss that
Yeah,
on May 27th or whatever it is.
absolutely.
And a lot of people who are coming to that course are not necessarily they're not coming to gain an understanding of how to manage vertical dimension, but it's such a critical piece of managing occlusion, managing function, and really properly managing aesthetics, that it has to be addressed in a course like this. And so we will spend a significant amount of time discussing when is it appropriate, when is it inappropriate, and
When to refer or when not to. Because like you say,
yeah,
like what we've taught before, Brad, in the Dental 4 program is, when Dr. Liam would teach how to open a vertical and treat TMD, like he would treat, this is how you treat 80% of the patients that are exhibiting very, very easily treatable symptoms. But then there's some complex TMD people that really, you just refer them out to a clinician that focuses 100% of their practice on treating those patients.
And how important is just to know that alone?
Exactly, yeah.
And just seeing that.
When to refer and when not to.
Yeah, that's right, yeah.
The reality is that opening vertical is, I think most dentists have the clinical experience and the intellectual capacity to properly manage changes in vertical dimension. But
That's a fair statement.
They lack the tools to properly assess how to do it and when to do it, and therefore lack confidence in executing a change in vertical dimension.
And heaven forbid, filling in the blanks where they shouldn't be filling in the blanks, making decisions that are like they think that it is informed, but in fact, they should pause and seek help.
Yeah,
right?
exactly. Yeah. So, Brad, are you going to be reviewing like a pre-screening TMD pathology protocol in the program?
Yes.
Okay.
Yeah. So that's a critical part of any exam period.
Yeah.
Even just on a routine exam, I'm looking for those things. But the one of the cases we're going to look at in the course is a smile that we're finishing right now together, and it's a beautiful case that I'm going to go through all the tools to show why this case is very safe to open the vertical dimension, and all the tools that we're using to pre-screen and make sure that it is safe.
Sure.
And, yeah.
And there you have it. I've had the camera on all day long, so this is the third podcast I've had today. You can't see me, but that's fine. Most of the folks just listen to this. And Ocean Ceramics, I've been through several of the Dental 4 courses and seeing, diving into this whole conversation. I've seen a lot of great clinicians coming out of the course, like with their eyes completely open. Bradley, I know the work that you're doing up in Kelowna. I know how close you work with these guys at Ocean. I have the privilege of coming and producing this course, and I'll tell you, like, the amount that I've learned in these conversations over these 2 days have been immensely impactful for any varying point in your dental career, whether that you're a Kois or you're Pankey or Spear trained doctor. No matter what CE you've gone to, these courses are always, like, I've learned a ton, and I'm excited. I alluded to the fact that we're having a conversation here to talk about smile design and courses. This is one not to miss, for sure.
So Mark, I don't know if I even shared with you, and Brad, I can't even remember if I shared this with you, but one of the core reasons why we approached you and says, hey, Brad, can you package up a Smile Mastery program, is because the trend that we're seeing in the lab is we have so many younger generation doctors that they're really great at doing single unit quadrant dentistry, but once they get these requests from patients, because everybody advertises themselves as a cosmetic dentist. So the minute that is up on the front window of their practice, patients are inquiring, well, what about a smile rehab or smile, makeover? And there's so many dentists that are like, oh my gosh, I don't know. We get the phone call. How do I prep a case for a smile? What's the best material? How do I bond? How do I do this? All these basics that you can do for simple posterior and quadrant dentistry, but when it comes to doing anterior work, open, maintain vertical, which burrs do I use in order to get the proper reduction, all these sorts of things. Well, at the lab, we're great at packaging up visions and material options after things are prepped. But when it comes to, hey man, what burr do I pull out? What's my burr selection sequence? That's not our game. That's not our core expertise. And of course, we know great bonding protocols, how to do that. But there's always these tips and tricks clinically that the experts have under their up their sleeve at any given time, and those are the things that we ask Brad to bring to the table on packaging up a course. And so that's what I look forward to. I don't know what your burr sequence is, Brad.
I got another secret camera angle here too. And another thing that I do want to mention too, in this conversation is, yes, the way to do it, but you guys talked about it. It's longevity, right? And let's do this let's do this thing and let's do it proper. And there's no corners being cut. We're doing this.
Because of all these things, if we don't execute the patient's emotional achievements or goals with the treatment. And that's the number one thing, because if we don't hit that and know that at the beginning, we're going to fall short somehow along the process. And, so these are the things that collectively we all want to achieve on that program, Brad, whether it's the Smile course here in May or the hybrid course in November. It's really the same principle. We're just restoring the teeth with different materials.
And Brad, how doing the work that you do, how passionate about it are you? And it's such meaningful work to have impact like this on people, isn't it?
It is. Yeah. I years ago I packaged up my thoughts on that in a book called Transformational Dentistry.
Oh, there we go. And, a shameless plug. Let's do it.
What?
I'll make sure that I put the name of the book in show notes. Let's dive into that. What's it all about?
Well, so the concept of transformational dentistry started with one patient who was suffering from bulimia and had for years. And I spoke with her. This was very early on in my career here in Kelowna. And I said, well, you really need to get this under control before we restore your teeth. And she came back to me and said, you know what? Fixing my teeth is part of my healing process. I need this so that I can heal. And it really opened my eyes in a new way to the power and the impact of aesthetic dentistry. I just delivered teeth to a young man. He's 22 years old. His first set of teeth.
Wow.
Yeah.
Never had teeth before, and now he's got a full set of upper and lower teeth fixed in place. It's completely life changing for a guy like that. I can tell you about Lori, who came to me with a denture and was just terrified of the dentist. She now has a beautiful set of teeth, and she ran for a position in a municipal election, which she never could have done without first, feeling confident in front of people. And so, I mean, this work that we do is meaningful. There's I'm drawing a blank on the guy who taught me how to use Botox, but he said Botox. I can't remember exactly. There's Dr. Braun down in Vancouver. Anyway,
Yeah.
he talked about how Botox makes the world a better place, because when you do aesthetic Botox, you can't frown anymore. All you can do is smile, and smile. The world smiles back at you. And it's
I love
the same thing when we give somebody a smile that they haven't had. They just, when you do those initial high smile photographs, and they're like,
Yeah.
no. Smile for me. And
We go,
Smile for real. Yeah.
I was like, I want to see how big you can smile.
Yeah.
And
Awesome.
and after they have the new teeth, you don't have to ask them to. They just beam, and the world smiles back at them. And so there's a huge emotional impact of what we do, and that's the thing that drives me to come back to work every Monday, is how can I impact somebody's life today? How can I help them have a better life?
well, you're
And
bringing their self-esteem from the floor to the moon.
yeah,
There you go.
it,
Is that a catchphrase in the course? Bring your
No, I just
patience.
came up with that on the
Oh,
fly.
you better write it down. Guys, this has been awesome. Little different setup that I'm used to. This was a lot of fun, and I will have the course information in the show notes.
Yep. And just to plug, I want to plug Mark. So we actually have a limited attendance of seats for docs at the course in Aldergrove. But what we are facilitating, because Mark's going to be on site broadcasting the course and recording it, that what we're going to do is facilitate that if offices want to have their staff also chime in, because it's so important for the staff to see what's going on, that for just a flat rate cost, they can have the staff at the office zoom in. Is it Zoom, or what platform do you use?
It will be Zoom. Yeah,
Okay,
Yeah.
so they can zoom in and be a part of the course, because it'd be impossible to fit all the staff in our teaching facility. So that it's so critical the docs and the staff are learning together all these foundations.
And it's all about that Monday morning. I see this across the board.
Yeah.
Get your staff there too. I can't emphasize that enough for anything. If you can bring your staff along on the ride, it's going to make your life that much easier. I've seen it firsthand. Brad, this is up for you. You're gonna impart us with some words of wisdom here. It better be damn good, man. It better be good. This is a big deal here.
oh, wow, so much pressure.
Yeah.
So I'm working on another presentation right now. It's called Simplicity Through Complexity.
Ooh, I like it. I like it already.
The idea being that, perhaps Monday morning when you go back to your practice, you're doing a DO on a 3.5. You're not doing a big smile. But when you study how to design an arch, how to design a smile, how to design an occlusion, all of a sudden that 3.5 DO takes on a completely more meaningful significance, because it is supportive of occlusion. It's supportive of the opposing tooth. It's supportive of the adjacent tooth. And I know some people think I'm silly for thinking about it this way, but I truly believe that if we approach a DO as part of management of aesthetics and occlusion, that we'll be more responsible in the way that we do that DO. And it doesn't have to be DO. It could be, whatever. But if we learn how to see every patient, every problem comprehensively, how it fits into their overall long-term care over 40 years of dentistry, it changes the significance of the little things we do. We see them as small pieces of a much bigger and meaningful picture for that patient over their lifetime. So simplicity through understanding complexity.
I love it. I love it. James, anything to add to that?
Closing comments. Everything Brad's talking about is really we're treating the person and not just the cause in whatever we're doing. And Brad knows that in the heart, but that's how I package that up in whatever we're doing, even on the lab side. We may not be face to face with the patient like all the clinicians and staff, but when we create a smile, that's what I want to be a part of, is transforming the patient, the person from the inside out with our dentistry. So can we just recap the dates of the course, Mark?
Don't even worry about it. Check the show notes, and also
Perfect.
Brad,
Okay.
I'll have your book in the show notes as well. Check out Brad's book. That's it.
Okay.
All right, we're good. It's 4:00, guys.
4:00.
4:01.
Brad's
4:01.
got to roll.
Brad, I got to rush too. So,
Okay.
guys, thank you so much. This was a lot of fun. Thank you.
Thanks, Brad. Cheers.